our first presentation on pediatric experiences. We have Margeaux, Akazawa, and David Delgado, both innovation strategists at Children's Hospital Los Angeles, and they're going to walk us through what CHLA is doing to address disparity, access, and social determinants of health for the patients and families they serve. So welcome, Margeaux and David, and take it away.
Great. No, thank you so much. I just wanted to check, is my sound okay? Can you guys hear me okay?
Yes, it's great.
Perfect. Great. Well, again, hi, my name is Margeaux Akazawa, and my colleague David and I are innovation strategists with the Children's Hospital Los Angeles. And we're so excited to be presenting with you today and to share with you two projects addressing social determinants of health and the power of human-centered design, no matter what phase you are in on a project. So located in the heart of Los Angeles and seeing patients from all across Southern California, Children's Hospital Los Angeles, or CHLA for short, is a nonprofit pediatric hospital with the mission of creating hope and building healthier futures for children. We see an incredibly diverse patient population. About 65% of our patients are Latinx. And in addition to being a top-ranked pediatric hospital, CHLA is a pediatric safety net hospital for the entire region, with over 70% of our patients covered by Medicaid. So when COVID-19 hit last year, we, like many other health systems, pivoted and moved towards offering telehealth to keep our patients, families, and staff safe. But we quickly saw that telehealth was not a viable option for all of our patients. Many of our patients don't have access to internet, some lack the devices that they need to take a telehealth appointment, and some lack a safe, quiet space to have sensitive health conversations with their doctors. So we came up with an idea to address this digital divide. What if we created virtual care hubs or private rooms or booths at community locations like YMCAs or other recreational and resource centers that our patients were already visiting, that are equipped with a computer, internet connection, and some other tools that they would need to take a telehealth appointment. But before we created these hubs, we wanted to apply human-centered design to test our assumptions, better understand the needs of our end users, and see how we could design a service that not only achieves this aim of increasing access to telehealth, but is also something that our patients and our families would love. And that starts by talking with people. We conducted interviews and focus groups with 8 moms who frequently went to a community recreational center with their children to learn a little bit more about their attitudes and needs around telehealth. So what did we learn? Our first finding was that parents did not know the term telehealth, but were familiar with the concept and used different words to describe it, such as FaceTime or Zoom. And so this illustrates to us that we need to be aware about how we communicate services and frame telehealth with less jargon, but in ways that our patients can understand. Our second finding was that while a few of the mothers we spoke with had some experience with telehealth, on the whole, most were not interested in telehealth, particularly when it came to their children. They felt that things would be missed by not having the in-person interaction with the doctor. So there is work on our part to better explain the benefits of telehealth and to dispel the myths and the quality of the clinical interaction on a virtual call versus an in-person visit. We also found through talking to these moms that all the moms that we spoke with had internet at home, but the quality of their internet was spotty and inconsistent, often dropping during the day or not having enough bandwidth for their kids to do online school. This is a really important finding because at CHLA, one of the ways that we assess if a patient can actually take a telehealth appointment is by asking them a simple yes or no question of, do you have internet at home? But what we found with these conversations is that all those moms would say yes to that question, and that actually we should dive deeper when it comes to questions about the digital divide. It's not just like yes or no, do you have access to this technology or not, but really the quality of those technologies and the connections to be able to support something like telehealth. And so we also asked our moms that we were talking to for their feedback on the idea of this virtual care hub. And to be honest, they were very ambivalent about it. Several were really confused by the concept and how it would work. And more importantly, many did not see this as a service that they would use. Most thought this would be better for the elderly rather than for kids. And this feedback clearly showed us that our idea, at least at how we envisioned it to start, would fail. We could have stopped the conversation there. We got some valuable information and feedback on telehealth and technology and tested this assumption around this virtual care hub idea. But this leads me to my first point. Listen to people and what matters to them. If we listen only to what matters to us, we are not truly designing with and for our end users, and we'll end up with designs that only meet our needs and biases. And that means allowing space in our conversation to go unexpected places. To illustrate the power of listening and allowing for this space, I want to tell you about one of the mothers we spoke with. We'll call her Anna. In a quiet voice at the end of one of the interviews, she said, "Can I ask you a question? It's not related to what we're talking about," but she then went and told me about the story that her father-in-law had died the week before from COVID. He was fine. Then he rode the bus to go see his doctor. 2 days later, he was in the hospital. My 4-year-old daughter has been asking me why she hasn't seen grandpa recently. And so, holding back tears, she asked, "How do I talk about this with my daughter? Are there books or videos that I can share with my daughter to help me explain this to her?" And this mom was not alone in her story of grief, pain, loss, and stress from COVID-19. In fact, COVID-19 was the #1 concern for all the mothers that we spoke with. Many had lost family or friends to the pandemic. Several had lost their jobs and were struggling to make ends meet and get food on the table. Those that still had jobs were having a hard time balancing their kids' virtual classes while still needing to go physically into work. And all of them felt like they had no time for themselves. So what did moms want? Well, they wanted mommy and me classes, particularly classes on healthy eating and exercise. They wanted childcare, even for short periods, to allow them to run errands and go to the grocery store without having to take all their kids with them. And they wanted resources and support around mental health for themselves and their children. If we had stopped or redirected the conversation back to telehealth, we would have missed this really rich conversation about what moms actually wanted and needed. And this brings me to point 2. Innovation can seem risky. And with hospitals and healthcare organizations tightening their belts and having to make really tough financial decisions due to the impact of the pandemic, innovation and different ways of doing things can feel too risky to take on. But in actuality, human-centered design de-risks new ideas. Through human-centered design, by engaging our end users in this process and by talking to them, we learned that our idea of this virtual care hub, as we had originally envisioned it, would not work. It helped us pivot our approach. It saved us back those resources, the time, and the money that we would have been spending on building and equipping a hub. And by allowing space in our conversation with moms, we heard what mattered to them, what was top of their mind. And we have started to explore new opportunities and creative approaches to address these real needs, including working with our child life services to provide a list of books in English and Spanish on death, grief, and loss for the community recreational centers to share with families. So this is an example that illustrates the power of human-centered design, particularly at the very start and ideation phase of a project. But like many of us, we often take on projects while they're mid-flight or already in process. And so I'm going to turn it over to my colleague David to share an example of how you can insert human-centered design to even work with projects that are already in flight. So David, turn it over to you.
Thanks, Margot. So I'm going to be talking today, as Margot just said, about how to use human-centered design to course correct or realign a project, even when it's near completion. So the project example I'm going to be using today is a project called Abrazos, which is a it's a hybrid digital and personal program that helps families follow up and utilize social services such as housing, food assistance, addiction services, and many others. So a little bit of backstory. Here at CHLA, any family who comes in with their child to the hospital, and actually many that come to our outpatient services as well, receive a visit from a social worker. And one of the many things that these wonderful social workers do with the family is to screen them for social services. So a few years ago, the social workers came to us because they had observed a trend. And they observed that Spanish-speaking and Latinx families within the communities that we serve follow up with social services less frequently than other patient groups and their families. And when they dug a little bit deeper into this, then they found that families and patients often feel that the list of social services don't fully reflect the resources that are focusing particularly on Spanish-speaking communities. And also that there are significant barriers to follow up when resources aren't bilingual. And we were surprised to find that that happens actually fairly frequently here in Los Angeles, and that wasn't noted on many of our lists. And this is true even when bilingual children or someone else in the family that can speak English was helping a monolingual parent. We also found that personal guidance and assistance is extremely important in any community, but specifically within the Spanish-speaking and the Latinx communities. So the team at CHLA took these learnings and they started to create a project. And it was looking to build a digital and personal program to connect the services and help families follow through with those social services, specifically targeting the Latinx and Spanish-speaking families that we served, with a desired outcome of promoting trust, enabling wellness and health, and navigating the cultural and linguistic barriers that exist within this space. And there was a design competition that was set up with local colleges, and the concept for Abrazos was created, with a fabulous goal of creating a CHLA mobile solution that families can trust and that facilitates human connection. The plan was created, an app development team was contracted, and the progress started. And when I joined the team just a few months ago and took over this project, the app was in its final stages of being built. Using it, families and community members could search for and filter lists of local social service resources, finding the best and the closest food bank or financial assistance program, housing resource, and more right from their phone. It was fantastic. And if they created an account with Abrazos, then the program could take it even one step further, connecting them with one of our community ambassadors who are trained in the local resources and could help the user find the one that best meets their need and help them navigate the paperwork, the enrollment process, and really be that consistent partner during the whole process. But the more I got familiar with the program and the more questions that I began to ask, the more it began to seem that the program, as well as it was built, was not quite meeting several of the key areas that it sought to address in the first place. First of all, the only social services resources that were shown in the app were the ones that were in our internal CHLA resource list. And this was the same list that our Latinx families told us wasn't really reflecting their communities fully. Secondly, there was no intentional design within this app around building trust in the referral process, which was another key area that the families told us was currently missing. And third, there was only a limited availability and ability for community building or interaction by our families. And users really had to search to find support if they needed it. Of the 4 areas that had been identified that we were told needed fixing, we had only truly addressed one of them, which was that building out of the community ambassador program. And so overall, we had kind of missed the point. If the project had continued as it was currently planned, we were in danger of creating a product that was for no one, essentially. The social workers had their system that worked well for them, and the Latinx and Spanish-speaking community, this didn't really meet their needs. So the question became, where do we go from here? To answer this, we started to dive back into the why. Why did we build this in the first place? We look back at the original purpose, to build a mobile solution that families can trust and that facilitates human connection. We had gotten that second part kind of right with the creation of the Community Ambassador Program, but the first part was severely lacking. But was this even the right purpose in the first place? We had to go back and look at the original problem, because as one of my favorite principles of human-centered design says, you have to fall in love with the problem, not the solution. So we re-examined the problem, and we found that it could be made a bit more specific to help us keep the project on track. We revised the problem to be that the lack of trust and or frustration with the current social service referral process at CHLA, which was felt by Latinx and Spanish-speaking patients and their families, leads to lower rates of follow-up with the social services. So even though it's a subtle difference, by specifically highlighting the current social service process as part of the problem, we made it clear that the solution couldn't just be a fancier version of the existing process, which is kind of what we had built. And by calling out the lack of trust and frustration as part of the problem, we narrowed our focus around what we should truly be addressing. So now we had just needed to figure out if this was in fact correct and matched the problem that we were seeking to find. So how did we do that? As Margeaux mentioned earlier, we listened to the people. So we talked to social workers, we talked to Spanish-speaking friends, we talked to community groups, we talked to our community ambassadors. we were fortunate that we had a slightly functional model of the app. And so we took that app as it existed and showed it to a bunch of people, had them play with it, got their reactions. We listened to how they think, how they felt, what they said, what they did. And the loudest feedback about the app that came back was around one specific topic: trust. So the question then became, how do we build trust within this app? How can we help people trust the resources trust that these resources work for them, and that this app and the community ambassadors were trustworthy? So the feedback we got from everybody was, first, we need to allow for the community addition of resources. As I mentioned before, the list of resources at CHLA, while they're fantastic and more permanent, they didn't reflect the local church that was now holding food banks on Thursdays in response to COVID, which for a family living in that neighborhood was just as important, if not more valuable of a resource than the official Los Angeles food bank that was maybe 3 miles away. We needed to establish a connection with the resources through community validation. Let people within that zip code, within that neighborhood, validate the resources, saying, yes, this worked for me. Yes, they spoke Spanish. Yes, they were able to address my need, while retaining their anonymity. We needed to prevent the need to repeat information, just as you wouldn't have to repeat over and over again to a family member as you were getting advice from them. We needed to find ways so that this continuity of information, this caring environment existed within our platform. And the loudest feedback that we got was we needed to change how the information was presented. We changed how, instead of making people have to work to find information about how their information was used, or who the community ambassadors were, and what function of different areas of the app were, we wanted to bring that information up front, make it in a video format, put a face to it, so it's easier to relate to and easier to understand. So the app and the whole Abrazos program is still very much under construction. And we know that we're going to have to continue to iterate on it if it's going to be launched and used successfully. But we're much more confident now that this is truly addressing the need it was created to meet. By focusing on the problem and not being married to the solution, we're currently building a much more elegant solution that will most likely have the applicability far beyond just the Spanish-speaking communities in Los Angeles. Both Margeaux and my examples use human-centered design to play an enormous role in avoiding the likely downfall of the projects we were working on. Because it is still new within healthcare, people often think, as Margeaux mentioned, that human-centered design will increase the duration and the risk of a project. But hopefully we've been able to show you that there are two concrete examples, at least, that show that this is something that can be challenged. Human-centered design is actually a powerful tool to reduce overall risk within healthcare, while also allowing for innovation and creativity to flourish. Thank you so much for joining us today. And if there are any questions, we'd be very happy to answer them.
Yes, wonderful. Thank you so much, Margeaux and David. That's fantastic. I commend you for the work that you're doing. We do actually have a really cool question, and it's from Niku, and they are wondering if users would expect to see CHLA-related resources on a CHLA-affiliated app. So how can you raise awareness among the target communities that resources aren't limited to CHLA?
So that's a great question. So we are partnering with we have a patient-facing app, of course, but the plan is for Abrazos to be separate from that. It is going to be listed as a resource within that, but then really targeted to the community in general. And so one of the things that we're trying to play with was this idea of different levels of validation, if you will, within the resources. So definitely still under construction. So any feedback, if you're willing to join us for some of the thought process, is having partnerships outside of CHLA like 211, which is a local LA resource, or partnering with different hospitals in the area and their social services resources, or Aunt Bertha existing platforms, and having the resources show up with a little tagline saying, oh, this resource is from CHLA, this resource is from 211, or validated by 211. And then the community generated resources would then have their own tag as well. And so this would allow kind of a distribution of the impact. So it's not just CHLA, but it's kind of co-sponsored by other organizations. And this would enable us to get the word out much further, I think, than we would be able to do if we were just doing it ourselves.
Awesome. Thank you again. I'm going to give you a round of applause.